Hi everybody, it's Dr. Linda of the VBF. Welcome to our annual Black Friday, and I'm in my black. You got some black on too. Our annual Black Friday VBF Facebook Live, all things Sturge-Weber. And I'm here as I am every Black Friday with Dr. Comi, the Sturge-Weber director of the Kennedy Krieger Institute of Johns Hopkins. And happy Thanksgiving.
Thank you for being here, everyone.
I'm just going to check here to see us on here live. So, yep, we are working. Oh, this is great. Everything is there. Let us know that you can see us. I already see there's 3 people on. Now, we have 1 hour to cover everything that we need to cover. So make sure you start asking your questions right away for Dr. Comi. We have some exciting things to talk about, some research that you've concluded, some things that are coming down the pike. One of the things we were talking about is trying to get the word out and the change in protocol now that new parents...
Right. So because we now have evidence that preventing or delaying the seizure onset is possible, first of all, and can decrease the early presentation of seizures and the brain injury that happens with those early seizures. Because we can do that now, it's very important that we try to do early imaging to make the diagnosis of brain involvement, because we're not going to put a baby who doesn't have brain involvement on low-dose aspirin and an anti-seizure medicine, or really any medicine. But if they have brain involvement, we want to not wait for the seizures to start or do imaging after a year of age, but get them seen as soon as possible and get MRI without contrast done as soon as possible, because in most places, it can now be done without sedation, and so the child is just fed and wrapped, and the MRI with all the right sequences and with contrast is done. And if we make the brain involvement diagnosis, great, then we can have the conversation about what's the extent of brain involvement and should pre-symptomatic treatment be done, what's the risk, what's the benefits, what do we know. If there's evidence of maybe brain involvement, then sometimes we end up having to follow really, really closely and repeat imaging to be certain. But it's important to be doing that early imaging now, back before we had any kind of treatment to prevent the early seizures, to prevent the brain injury, to improve outcome. Then we often waited because early imaging wasn't able to exclude brain involvement. But now that we can offer treatment that's helpful, that really just, makes it very important that children be referred very early as soon as somebody thinks about Sturge-Weber syndrome, and that we do the early imaging to try to make the diagnosis.
Now, by early, let's talk about birth. So obviously the stains are there at birth.
Yes.
And we always say it's like the mask, like around the eyes, the temple, the forehead, right up to through the hairline.
Well, it's really, not so much in the hairline, but the forehead, the temple area, and the eyelids, Yeah,
upper and lower.
Yes.
So because the baby's not as wiggly and much more cooperative in that first month or 2 of life, you'd really like that done in the first month or 2, right?
Yes, after about 2 months, it depends on the baby, but after about 2 months of age, it's no longer possible to do a non-sedated MRI because they have to hold perfectly still. And little babies, you feed them, swaddle them, and put them in the scanner, and they just sleep right through it, and they hold still, and you're usually able to do that. But when the baby gets bigger, it's not really possible to get a full MRI, especially with contrast, because you have to put the IV in, and that hurts, and so the baby cries, and then you can't do the MRI.
So it's much more compassionate, really, to do it before age 2 months. It's more informative for you
Well, it's reassuring if it's normal, but it doesn't fully exclude the brain involvement. It's just that, again, now that we have a treatment, we don't want to miss those children. We want to try as hard as we can to make the early diagnosis. I can't say that the imaging is, I mean, it's helpful. If we don't make the diagnosis of brain involvement, we still end up following them as we did before. But we're trying harder now to really make the early diagnosis, because now we have a treatment that we can offer. Before, I mean, there wasn't anything that was necessarily being offered that made a difference. Now we have a treatment to offer that makes a difference, and so it's really important to try to make the diagnosis of Sturge-Weber syndrome brain involvement so that we can offer the treatment.
And the earlier the treatment, or the soon as you get the diagnosis, if there is something, and you put them on the medication, that's protecting their cognition, correct?
Well, so what we have now is that it reduces the frequency of early seizures in the first 2 years of life from 90% to 50%. That's not perfect, and so we're still working on even better management or treatment strategies, but that was very significant. And the neuroscore at 2 years of age was also better, and so yes, we have early evidence that it improves neurologic function by 2 years of age, and we're also now following children who have been pre-symptomatically treated and who are now 6, 7, 8 years old and who are doing very well. It is not effective, or not as effective as we'd like in everybody, but it's offering hope for preventing those early seizures, which worsen blood flow in the brain and frequently result in brain injury. Yes.
So we have some questions coming in for you, Dr. Comi. Ruth asks, besides the location of the port wine, if we haven't been diagnosed with Sturge-Weber, what other signs or symptoms can indicate potential brain involvement?
The most common presenting symptom is the early seizures and twitching. So if the birthmark is on one side, twitching, or eye deviation, the hand, the foot, the side of the face, the child, and you can't stop it, it just keeps going. And
you talk about the fisting.
Early-handedness. Well, early-handedness, babies don't become right-handed or left-handed until a year, 18 months, 2 years of age. It depends on the child, but a baby who's 6 months old shouldn't be handed. And then children can also develop a visual gaze preference or deficit where they don't see well off to the side opposite again of the birthmark, and so that's also, children can develop a head turn, or just they appear to not see off to one side, and that's another indicator of possible brain involvement, which is why we take a developmental history when we see the children, and we follow them pretty closely in the first year of life. Take a history, do a good exam looking for evidence of early-handedness or visual field deficit or other just abnormality on exam, neurologic exam. And we also do a lot of EEGs, because EEG is like an EKG, where you put the leads on the chest and look at heart function. EEG looks at brain function, and it's completely safe. There's no medicine, there's no radiation, and we're able to see abnormal activity We also use that to monitor response to the pre-symptomatic treatment. So if the EEG is abnormal, we start the pre-symptomatic treatment, we're looking for the EEG to normalize.
Thank you for that. Shamai wants to know, what if early MRI doesn't show involvement? Is it still recommended to use preventative medicines if the birthmark is extensive?
No, because I have seen patients with extensive birthmark who don't have brain involvement, and in fact, some of those children, we end up doing genetic testing because they have something else. They have a different mutation, a different syndrome, and so we're thinking about other things when sometimes it's the same mutation, but you're right that a very extensive birthmark increases the risk of brain involvement, but it's still nowhere near 100%, and we wouldn't want to treat, put a child on two medicines for the next 5 or 6 years if they don't have brain involvement.
Yeah, that's a good answer. If you're lucky enough, and we get this early message, really common practice, and these babies are being imaged by 1 month and they're completely clear, what is the probability that they could still have brain involvement down the road? I mean, if it's clear at 1 month, is it guaranteed no brain involvement?
No, it's not, and which is why we try to make the diagnosis early so that we can get ahead of the seizures and have a good chance of treating pre-symptomatically. But if it's normal, we still follow and do history exam, EEG at like 3 months, 6 months, and if everything is fine, then most of the families currently still get imaging done after a year of age to fully exclude brain involvement.
Would that exclude it if they
Yes.
had one at 1 month and then after one?
Imaging with and without contrast and the appropriate sequences excludes brain involvement after a year of age, yes.
Well, that's fantastic to know for these families. So thank you for that question. That was an excellent question, and we're here, so Dr. Comi can take more of your questions. And I guess I have one too. So now I know obviously you aren't a glaucoma expert, and we do referrals for patients for glaucoma, but if you see brain involvement, do you automatically refer them to have a glaucoma check?
If they come to me just with the birthmark in the high-risk area, then and they have not already seen an ophthalmologist, I'm referring them. So the infant who has the high-risk birthmark has an increased risk of brain and or eye involvement, so they can have both brain and eye and skin, or they can have just skin and brain, or skin and eye,
Or brain only?
or brain only. But they're not they're not coming to us as babies with the birthmark.
No, because there's no birthmark. There's no signal.
Right,
Yeah.
exactly. But it's very important that they're seen by the glaucoma specialist or a pediatric ophthalmologist, and that they're getting evaluations done every few months, really, in the first couple of years or so of life, because for those who have eye involvement, there's a very high risk of glaucoma in the first couple of years, that there is an elevated risk that persists after that, and evaluations should be done about every year, to even after childhood into adulthood. It's really important because there's another kind of glaucoma that can happen, and so it's really important that the eye doctor not tell the family that they're in the clear, they don't need to go back. That's very important.
I agree, and there's a lot of people that get that message, and then I tell them, no, you have to keep going. And they're like, oh, the doctor said I don't have to. I'm like, nope, you have to keep going.
And find another doctor.
And and another thing that's been interesting is they'll get told, oh, that's a choroidal hemangioma. You don't have Sturge-Weber. And I'm like, no, it's not just glaucoma. It's there's multiple eye involvements, but it is
Right.
all part of the same quote syndrome.
Right.
We have Steve Kemp. He's like,
Okay.
hi, Dr. Comey. Steve and James Kemp from Tennessee. We were in your study back in 2015.
Yeah.
Hope you are well. Happy
I
holidays.
hope James is well.
Yes, so that's cool. And another one, Gio Dan, hello, glad to participate. What do you think about this procedure? Laser interstitial thermal therapy, LITT, is a minimally invasive neurosurgical procedure that uses a laser to ablate or destroy abnormal brain tissue, such as tumors, and is guided by real-time MRI, magnetic resonance imaging. This procedure can be implemented to SWS patients in brain surgery, question mark?
So, to my knowledge, that hasn't been used, and I could be wrong, maybe it has, but for closed surgery in patients with Sturge-Weber syndrome, really the concern is that there's a lot of abnormal blood vessels there. And so, and it just would be harder to control bleeding. But I can't say that things won't have, certainly surgery has been getting simpler and safer and going from removing the brain tissue to disconnecting the brain tissue. And so, it's possible that something along those lines could be part of surgical procedures in the future.
Well, one of the other things that I've been very interested in is this HIFU, the high intensity focused ultrasound.
Mm-hmm.
Now they're using it on glioblastomas, they're using it on vascular conditions. And I wonder and hope, because it has been so successful with even Parkinson's
Right.
and other things, and it's not invasive,
Right.
So
I mean, something that can destroy the area of tissue and prevent bleeding at the same time, or disconnect the tissue and prevent bleeding at the same time, I would think would be helpful. But it's certainly not, to my knowledge, sort of mainstream at this point.
But I'm going to look into that LITT. I like reading about anything new that's out there. So thank you for that. So Ivy says, is there an organization or foundation that can help with treatment or support for port wine? My friend has a burgundy port wine birthmark on her face. What is the recommended evaluation or treatment for this?
I'm presuming this is an adult, perhaps with a thickened or darker birthmark, and the laser techniques are improving, but I would recommend reaching out to the VBF, and it is more difficult to treat the birthmark later in life when it's darkened and thickened and blebbing and all of that. But there are vascular dermatologists connected with the VBF who are, very expert in that, and they can certainly go through with you what the best options are for you.
Agreed. Ivy, on our website at birthmark.org, you'll see experts. I don't know where your friend, what city or state or country they're from, but we list the doctors that do laser treatments. We also have free clinics every year. So we have one in Miami that will be the end of March. We have one in Bucharest in July, and then New York in October. So you have to go to our website at birthmark.org. Most all of those clinics they're not there yet. We haven't launched them, but we will be very soon. So keep following us on our web page here on Facebook, or our Facebook page here, facebook.com/Vascular Birthmarks Foundation, which you're on right now. So you can follow there, or you can go to our website. And that's where, if you want to write to me, vbfpresident@gmail.com, you can send me some pictures, and I'll communicate with you or her and maybe get her in to get a free treatment and go over if it's near her eyes, she'll have to have the eye exam.
Right, absolutely.
And also maybe an MRI if it's...
Particularly if there's any headaches or, cognitive changes or anything that would indicate brain involvement, then if appropriate imaging has never been done, then an MRI with that contrast should be done.
This is an interesting question. If a later MRI at 2 years old does show brain involvement, how long should we give preventative medicines?
So that is that would be dependent on how extensive the brain involvement is and how generally we give preventative treatment until at least 5 or so years of life. We want to get past those first few years of life, past where the deterioration in glucose metabolism and atrophy frequently happens to the brain, and ideally get them off of the medicine before they start school, like kindergarten, first grade. So the situation that you ask about doesn't happen very often, because 90% of those who are untreated who actually have brain involvement will have onset of seizures before 2 years of age. So that doesn't come up very often. And it certainly would be sort of a situation to sort of consider risks and benefits, and depending on how extensive the brain involvement is, because that can be just a small area in the back, or it can be both sides, it can be the entire side, or it can be the entire brain, and that sort of gives you some idea of how much brain is at risk of injury and drives some of the discussions around pre-symptomatic treatment.
Thank you for that. Steve wants you to know that he will be 18 in January.
Oh, okay, wow.
I know all of the patients that have gone through VBF now. We have 31 years, so they're all growing up getting married. It would be great to reconnect, so, feel free to reach back out, to give an update if you'd like. Yep, and Dr. Comi's email, Kiana can post it here, so you can just reach out to her. Thank you for that. So Kevin, our favorite Kevin from Romania that we always see, his mom and dad say hello from Kevin, and we'll see him in Bucharest.
Right.
So, okay, on that one, Katie wants to know, my son has a light patchy port wine stain on the temple, forehead, and corner of the eye. He is now going on 8 months, and our neurologist wants to wait on imaging, even not suggesting it, thinking he seems fine. I, however, am pushing to do it. How do I know that they will be doing the right sequencing? It worries me that they seem not to think he has any issue and something could be overlooked. He is developing normally and no signs of seizure, but the placement has me worried.
That is a at-risk placement. It's good that he's gotten to 8 months of age with no problems. You could push for, again, an EEG, which is completely safe, doesn't require sedation. But you could also, if the history exam is truly normal, I would do the EEG too. And if all of that is fine, then getting the imaging after a year of age is certainly reasonable. It's a long list of sequences, so you can reach out to me if you would like, and I can send those. I'm also happy to look at imaging after it's done. If it's abnormal and there are lots of questions, then I ask families to sort of establish care in some form. I do chart reviews and telehealth internationally, telehealth in Nebraska, Tennessee, Minnesota, and Maryland, and patients and families just have to be physically located in those states at the time of the evaluation. They don't have to live there. Or of course in person, but I do look at images. If the question is, they've told me it's fine, would you please take a look? I'm happy to do that. So.
Thank you for that. Erica says, hi, Dr. Linda and Dr. Comi. What are your thoughts? Oh, I can answer this one. On the daily and or weekly laser treatments for newborns. I know it's been shown that weekly have been successful, but what about the daily? Well, Dr. G and I just did the 5 and 5, and he's going to be presenting that at the ASLMS meeting in May, and the result is conclusive that it is successful. Of the 5 that were treated, 3 of them had what we would call complete clearance, which is 80 to 100% clearance, and then another one got a 6 treatment and reached that 80. The other one had a very deep, intense one and got about 60% clearance, so they'll stay with it. But Dr. Geronimus has concluded that the 5 and 5 is a successful, and he got them, like they were all less than 2 weeks of age when he did it. And the weekly's been published as successful. So again, this goes along with your early.
Very much the bottom line is, early for the eye, because you want to catch the evidence of eye involvement in glaucoma and start treatment, or get them in for whatever surgery or procedure they need before the glaucoma has resulted in eye enlargement or vision loss, because those things don't go away. And same thing with regards to getting them seen early and early imaging to try to make the diagnosis of brain involvement before the onset of seizures and big problems and brain injury, and also for the skin, so because the early aggressive laser treatment is very effective, and the child doesn't remember it, and so.
And the head is this big.
Yeah.
And so the spot size is now 15 millimeter, and it's like
very
5
fast.
gaps.
Yeah.
And it's quicker, and it goes deeper. The new Pro laser is the way to go. Geo Dan, apparently I don't know if that's just their Facebook name, but it said they want to thank you for everything that you've done for CESAR, CEZAR. And he's the one that mentioned that LITT procedure.
Okay.
And then Ruth Dub says, are those free clinic dates listed on the VBF website? It would be great to know the dates ahead of time so I can request time off. Well, we just, we haven't published them because we just settled them all this week. So stay tuned. We did put out the save the date for Romania, which is July 11th, okay? Miami is March 28th, that's the last Saturday. And New York is Columbus weekend. So those are the 3. We might be adding a 4th one for physician training in New York City, but that will only be for babies. So you can, those are the dates. Lots of people on. Thank you for your answers regarding, I asked earlier, my friend is 30 years old living in Rochester. Okay, I'm in Albany area, so that's close to me. She would go to Dr. Geronimus in New York City. She was born with the port wine on the right side of her face. Its color is becoming very dark and bluish. I wanted to ask if there is foundation that can help her. Whatever insurance she has, I'm pretty sure if Dr. Geronimus doesn't accept it, Dr. Bernstein will at the Laser and Skin Surgery Center. Otherwise, we have negotiated with Dr. Bernstein and Dr. Geronimus for a flat fee of $750 for any laser treatment. But we're the only ones that even do the free clinics, so that our free clinics are the only ones that there are that I know of. I don't know of any other free laser clinics, but nothing in the Rochester area are, and I know because I'm in Albany, so that's only a couple hours from me. We don't have a laser expert there, but you can try and see if you can find someone that's got like a pulse dye laser. And, run it by me. You can always write to me and ask me, but that's the information. So Jason says, with brain involvement in the infant, what age range is the highest risk of seizures present? Is there an age where it goes down significantly?
Yes. Usually it can happen in newborns. That's uncommon if they have brain involvement. Usually if there's brain involvement, seizures, the risk of seizures starts going up around 3-4 months of age, and 75% of them will have seizures by a year of age, and 90% by 2 years of age, if they if they have brain involvement. And the other 10% can have onset of seizure anytime after that. I've seen children, teenagers, adults, young adults, older adults. It is also possible to not have seizures. I've seen adults who have, it's rare, it's uncommon. Patients who get to childhood and later who've never had a seizure, they do really well. The seizure in the babies with Sturge-Weber syndrome can be very severe, repetitive, lasts for a long time, and it further decreases blood flow to the brain. And that's where a big part of the problem is that the seizure can cause further decreases in blood flow to that area of the brain and injure the brain. And then once the brain is injured, the rest of the brain may adjust some and be able to compensate some, but it's very difficult to make that brain injury go away once it's happened.
Thank you for that. So Ivy, Kiana, who is our director of our Global Ambassador Program, has already or will post in the comments section my email, which is vbfpresident@gmail.com, or Dr. Comi's. She can post both. Both of those will be there. If you have any issue, just email me at vbfpresident@gmail.com. Erica says that if an MRI is clear at 1 month, I will understand the recommendation is to repeat it closer to 1 year. What would be a warning sign, or what would a seizure even look like for a baby less than 1? How would you help them?
So they should be seen by a child neurologist and have an EEG done around 3 months of age, around 6 months of age, and then seizures are not these big shaking all over the body things that you see on television. It's much more subtle twitching of the hand that just goes on and on and on, or twitching of the foot that just keeps going and going and going, minute, 5 minutes, 10 minutes. It can be twitching in the side of the face that just keeps going, or the eyes deviated and bouncing. And the other, with the VBF, with Linda and the VBF, we also studied the use of infant monitors to try to make sure the child is safe, like when they're sleeping, when the parents are sleeping, and did find that that these infant monitors, which detect heart rate and oxygen saturation, can also pick up on seizures. And there were multiple patients in the study that where the infant monitors did pick up seizures, and so I think that's also very helpful, because once families know about this risk and realize that seizures can happen when the child is sleeping, it's not necessarily a very noisy or obvious event, but can go on for a long time and can injure the brain. Yeah, that's obviously very stressful for them. And so something like the outlet monitor, one of the infant monitors that monitors heart rate and oxygen saturation is helpful, because seizures, if they go on for a long time, cause the heart rate to go up, and if they go on for a really long time, the heart rate can go down to too low, and also cause the oxygen saturations to drop. And so I think that the questionnaire, the survey that we did, indicates that the monitors were easy to use, that it helped families sleep better, not worse, so it wasn't, and that it was also effective in picking up seizures in the babies with Sturge-Weber syndrome brain involvement.
Okay, thank you for that. And I think it's Kiana, I'm not sure who is on for VBF, but if you could post the emails I just put mine in there, but if you can post Dr. Comi's as well. Oh, yeah, I see mine.
It's Comi at KennedyKrieger.org.
Okay, thank you for that. Another one from Ashley, female, 55 years old, port wine stain on forehead and center of nose, no glaucoma to date, another number of physical and mental health diagnosis, but no Sturge-Weber according to 3 different neurologists. Neuro saw AVMs, no surgery required. What do you recommend? I've been in touch with Dr. Linda in the past. She may remember.
Well, if AVMs are found, then definitely need to be in the care of neurosurgeons, and also definitely need to get genetic testing done, okay? Because increasingly there are inhibitors, medications, so that, if surgery is necessary and it's an option, that's one way to go. But the other is sometimes the vascular the AVM is not in an operable place, or it's in a really high risk place. And there may be an inhibitor that would be a better option, a medicine, a drug. But the only way to sort of know what would be an appropriate medication is to get the genetic testing. And it's important to know, and you can start with genetic testing in the blood or the cheek swab, and that may show the mutation. But we published a series of patients a couple of years ago showing that you can start with that, and whole exome sequencing should be done. But if that's normal and doesn't show anything, or if it's very obvious that that only this area of the body is involved, then really it needs to be a skin biopsy still to diagnose the somatic mutation, because in those situations, in most cases in Sturge-Weber syndrome and in many situations where the vascular malformation is just in one place in the body, the mutation is not present throughout the body, especially if there's no family history, there's nothing else there to suggest one of the sort of inherited, very rare genetic conditions. And so then in those situations, getting blood work done or doing a cheek swab, it's not going to show anything. You have to actually take a small piece or biopsy of the area where the birthmark is in order to be able to detect the mutation.
Yeah, and she and I had communicated, because obviously this would be what ISFA now calls a CM, AVM,
Right.
and the biopsy genetic testing would show a RASA1 mutation. And I'm not sure if
that's one possibility.
One
Yep.
possibility. And what I've been finding with the CM-AVM patients is, as soon as I start talking to them and taking a history, I find out, oh, my grandfather has.
Right.
It's very familial,
Right.
it seems.
Right.
But most people, they just live with them if they're small little stains with tiny little fistulas or something, like, we've seen.
Or they just don't link it.
Yeah,
they don't realize
Make
that
the connection.
that it's actually a vascular issue that's running in the family. But yes, that's unusual, but it definitely can happen. And what you're describing, it would be very important to get genetic evaluation.
Agreed. So the question, this one would be, I know the answer to, do you know when the new laser, the Candela V-Beam Pro, will be in Europe? They are still sitting in Malaysia due to the tariffs and haven't left yet. They were supposed to be there in June of this year. They were supposed to get delivered, then it was delayed till November, and now it's supposed to be in the spring. So, because there's a lot that haven't even been delivered in the U.S. Right now, still only the 4 places that got the originals that were built in Boston are the ones that have it, like Dr. G, Dr. Friedman, Dr. Bernstein in New Jersey, and the doctor in North Carolina. We have that list on our website with the ones that have it. I'm not sure if we'll have it in Bucharest. I'm hoping that by July, when we're there, that they'll be in Europe, and then Candela will be able to bring one. But for now, the Bucharest, we have the 3 perfectas, so we'll have enough lasers. Okay, looks like we're caught up, so if you have any more questions, we're happy to take them. A question on the baby monitor, and you and I have talked about this, because I love the idea.
Yeah.
And I've said this too, like, I think all ages should have them, like...
Yeah, so, I mean, patients who are older but still intermittently have seizures, or live alone particularly.
Or like we had two college girls who had to leave school because they were found on the floor from having a seizure.
Right. Yeah, I do know that, you know, some families have gotten like the wrist monitor. You know, there are a few different ones. There's also now the in the form of a ring. These don't really, they're not made for or well suited to toddlers or very young children who might try to eat them, get them off, play with them, swallow them. So they're not, but for older patients, that, you know, that can be very helpful, where, you know, they want to be in their own room, they want to have their independence, but still have that sort of backup, or be able to get help if they need help. There is something called MFIT, or vibration pads. They go underneath the sheet, and if that's going to be effective in like a toddler or a young child, it depends on what kind of seizures they have. So if they have a convulsive seizure, then it will pick that up if it's a strong enough convulsive seizure. If all they have is eye deviation and staring, that it's not going to pick that up. So, you know, that's helpful for some patients, but you know, good website for like thinking about some of these options is the Epilepsy Foundation website. They have information on seizure detection systems and equipment, and that is moving forward. And I think our study was really helpful in showing that in babies who have a high risk of seizures, particularly in this situation where the brain is at risk, it's very helpful, because, you know, yes, there can be some alarms when the child is fine and that sort of thing, but on balance, the family sleeps much better, and it can pick up really prolonged seizures, which is why the families sleep better, because they know that there is this backup to keep their baby safe. So yeah.
I thought I read it, but maybe I was wrong. Doesn't the monitor pick up like a slight? Isn't there an increase in blood pressure or something that occurs?
It's heart rate, increased heart rate, and decreased saturations. Okay. You know, when a seizure, and some of the monitoring systems, like the one I usually use is that, or write scripts for, is the Owlet Drain Monitor, which is a little booty that goes on the foot. And if the doctor orders it, you can get it so that the parent can set the heart rate and the saturations. If you don't get that version, the one that's just available online, they set the heart rate really high, and so it's not as helpful. It's not as sensitive for picking up a problem. So I write. That's a new thing in the last year. It didn't used to be the case that I needed to, or a doctor needed to do that, but you do now, to get the setup where the family can, and that's really helpful, because the family can see how the child does in the first night or two of sleep, look at what the recordings show, and then set the settings so that the heart rate is, 10 beats per minute above where they normally are when they're sleeping. And that can be adjusted with age, because the heart rate comes down. You know, it's quite high in the very little ones, and then it starts to slowly come down as you get closer and closer to a year or two. So it's important to try to get the setup where you can adjust the settings to be outside the normal for that sex and that age of the child, but not so high that it's not going to pick up anything that you need it to pick up.
Will it pick up increased heart rate in an adult as well? Does an adult that's getting ready to have a seizure have that increase?
Yeah.
'Cause
But
if
the problem is that those systems are not made. You can get pulse ox.
Yeah, I was going to say or the Fitbits now, or the rings,
right.
or whatever that are specific for picking up heart.
Yeah.
So Ashley, the one who we talked to about the genetic testing, said, my paternal grandmother had bad varicose veins in arms and legs, and my dad had a red birthmark on his back, and no one knew until he passed away. Is this what you mean about genetic?
Could be, and it's important to bring that information to the geneticist, and they'll sort of help you work through that.
We only have 14 minutes left, so please make sure you get your questions in. Jason said, thanks for the percentage of seizures by infancy age. What does the percentage of seizure go down to with preventative 𝗧que𝗶𝗰?
It goes down from about 90% by 2 years of age to about 50%, and it's 𝗧que𝗶𝗰 plus, or the most common is 𝗧que𝗶𝗰 or levetiracetam and low-dose aspirin. Just one or the other is not as effective. We studied that, and so it's the combination of the two, because it's not just an epilepsy, it's not just a cause of seizures, but it's a vascular malformation in the brain that affects blood flow. And so the 𝗧que𝗶𝗰 or the seizure medicine is sort of preventing the seizure activity, and the low-dose aspirin is improving blood flow through the abnormal blood vessels. And so, currently that's what we use.
And I just want to restate something, because it's so important, especially right now where there's a lot of passivity with referring infants for testing, that what we really need for parents to understand is when they have those seizures, after the seizures, there's a permanent reduction in blood flow.
Well, there's actually, we call it atrophy, meaning permanent brain injury that calcifies and shrinks the brain.
Right.
And once that's happened, you can't go back.
Right, which is why those of the parents that are writing saying, I want to push they got to push them, or do a consult with you, or do a telehealth with you, or go to Baltimore and see you, because this is their life.
It is a big change over, and for practicing physicians who were trained one way to think about this for hundreds of years, it was, well, if the seizures start, we'll treat them. But this changes the whole approach, really, and provides hope that we don't have to just sit back and wait and see what happens. But for the children who do in fact have significant brain injury, we can intervene and make a difference. We have, I can't go into the details now, but we have a new study being planned, hopefully to start in the coming year, to further improve on those options. So we are continuing to work on that, because we want the risk of early seizures and brain injury not to go from 90% to 50%, but eventually 90% to 10% or 5% or 0%. It should be, we need to get out the word that this is an opportunity to make a difference in a syndrome that causes brain injury in babies and prevent that. And so that's really what we want to do.
Thank you for that. So this cover is 𝗧ına. 𝗧ına was our model, and you can see she has that port wine stain. This was our program, between her eyes and right on the forehead. What risk would you give for that one?
Yeah, I mean, if it's midline like that, I mean, it is about a 25% or so chance of Sturge-Weber syndrome brain involvement. I would say if that extends down onto the bulb of the nose, we're worried about AVM, that particular distribution. But if it's just on the forehead, they may have no brain involvement at all, but they can. And so
you would recommend she get an MRI?
Yeah, if she's not, in particular if she has bad headaches or is having any cognitive issues or problems or has ever had anything happen that seems like a seizure. I have absolutely diagnosed patients with Sturge-Weber syndrome brain involvement with that midline forehead distribution.
Yeah. And she's got some blebs on it. And that was the thing that I was talking to Dr. G about that we should look into is, do the patients that develop the blebs early in life, how does that correlate to Sturge-Weber? Only because these are so progressive.
Yeah.
Because they're so hypervascular. We were just talking about it because I was saying, why do some get blebs and some don't? And we've seen kids as young as 5 years old with the blebs. And then I remembered one of the kids with the blebs at 5 also had Sturge-Weber. So it made me wonder, is that an indication?
I mean, I've seen a lot of patients with Sturge-Weber syndrome brain involvement, and I would say generally no. Generally, it's very uncommon for kids, young kids, to have blebs. I would say that would be an indication for genetic testing, perhaps. And I would also wonder, have they had a lot of sun exposure, perhaps? What other exposures have they had a lot of? We want the babies and the young and the children, and really any patient who's got a vascular birthmark on their face, a capillary malformation, a port wine stain on their face, to protect that skin from the sun. So, we talk about wearing hats and sunblock and wearing UV protective sunglasses to keep the sun away from the involved area, because we know that there is a mutation there that's caused the port wine birthmark, and that mutation is also considered a driver mutation, meaning that it, with sun exposure, with time and age, increases the risk of additional mutations, and that probably at least partly accounts for the blebbing, the darkening, the progressing that some patients see. Yeah.
Well, we are coming down the pike. Erica wants to know, is it normal protocol to put babies on aspirin to prevent seizures if they have a clear MRI at 1 month?
No, I don't treat pre-symptomatically, and I follow them very closely. And if the MRI is completely clear, we're sure that there's no evidence of issues at all, then bring them back at about 3 months of age and do another history exam, EEG. And if there's a problem or concern that develops at any time, or if the early MRI is not diagnostic, it doesn't show clear brain involvement, but it's concerning, then we'll repeat the MRI. I don't put a baby on treatment if the imaging is fine, because I'm uncomfortable. I don't know whether that treatment how that treatment pre-symptomatically changes the MRI, and then it becomes a difficult question of when to stop that treatment. And it can that's an unanswered question, and also because the treatments, they can have side effects, and I don't want to put a baby who has a normal brain on low-dose aspirin and an anti-seizure medicine, which can have side effects. It's often well tolerated, but there are some babies who can have sleep difficulties, fussiness, just behavioral changes, and we can address that if the child has brain involvement. There are other options, other anti-seizure medicines, but I'm uncomfortable with just starting a medicine in everyone who has a birthmark because, only 20 to 25 or 30, maximum 50% of, depending on the size and extent of the birthmark, have brain involvement. And so a lot of babies don't have brain involvement, and I don't want to put them on medication if they don't need it.
What percentage was that you said?
I mean, it depends on the extent of the birthmark. So if
Right.
it's a small, forehead or eyelid, about 20%. If it's larger and covers, much of one side of the face or is midline, it's more like 25 to 30%. And if it's over both sides of the face, it's, between 40 and 50%. So it does vary some. And if there's a question, we're, going to be more aggressive with in terms of monitoring and trying to make the diagnosis in a child who has a higher risk birthmark than in a child who has a lower risk birthmark. But still, we really shouldn't be starting patients on treatment who don't have brain involvement that's been diagnosed.
Thank you for that. Ashley, who was communicating before, and I showed this picture with the midline, part line, she said that's what hers looks like, and it goes across her forehead and down her nose.
Mm-hmm.
So would you recommend she get an MRI to make sure
mean,
there's no AVM? Or?
She should have an MRI. I mean, if she's never had an MRI, she should have an MRI. The other possibility would be to get an ultrasound of the area and just
Yes.
make sure. But it's really not an AVM necessarily in the brain that I'm worried about as much as
In the skin.
in the nose, in the skin.
And we do those ultrasounds
Mhm.
at our
Yeah.
annual conferences and
Right.
clinics. So, well, it's been a very busy day and exceptional Facebook Live. And for all of you that are on right now, you can go back and rewatch this for 30 days. It'll be there on our Facebook page. But we will also move it to our YouTube channel, which you can watch and rewatch. And you can go back and see Dr. Comi throughout all the years doing the Sturge-Weber updates with me. And we have 2 minutes left, so I'd like her to touch a little bit on a topic we didn't talk about yet, which has always fascinated me because of my master's in nutrition, is diet and Sturge-Weber. Is that still a thing where we try to...
Well, I would say that... So, in the page, I have used like the ketogenic diet or the Atkins diet or something along those lines in babies who've been refractory to multiple medications. It's not a first choice because once you get beyond infancy and start getting into food, you have less and less control over what the child gets all of the time. And they break their diet at all, then they're going to have seizures if that's the only thing that's controlling their seizures. But it can be helpful in patients who have failed multiple medications, aren't a good surgical candidate. It can help. I have seen patients whose entire family ate the modified Atkins diet and it controlled the child's seizures. It can even be used preventatively. It's just very difficult once you get beyond infancy to maintain the diet at school and at friends' house and that sort of thing. Generally, I recommend a healthy diet, so lots of fluids, lots of and a healthy fresh fruits and vegetables, Mediterranean fish, lean meat, avoiding of junk food, basically. And so I do think that is helpful, along with getting plenty of sleep and trying to keep a regular schedule that brings down stress for a child. So yeah, all of those things are an important part of taking care of any child's epilepsy or headaches, that kind of thing. So
Well, thank you, and we are on the hour and on
Okay.
the end, and you can see Dr. Comi in July in Bucharest. She'll be
Right.
doing the Sturge-Weber assessments for free at our super clinic, and also again next Columbus weekend in New York City. Her phone number, her email has been posted throughout the string, so you can reach out to her to coordinate a telehealth or whatever kind of an evaluation you would like from her. So thank you very much.
And thank you, Linda.
Yeah,
It was my pleasure.
Happy holidays coming, and stay safe, and we will see you again soon.
Take
Thank
care.
you.
Bye.